You know that feeling when you take a really deep, satisfying breath and you just feel better? Like your body got exactly what it needed.
That vital intake.
Well, today we're diving into what happens when that most fundamental need, oxygen getting into the bloodstream, isn't being met properly in our pets.
Yeah.
We're talking about hypoxemia.
Exactly. And for this deep dive, we're looking at information from key veterinary medical texts, all focused on this condition in dogs and cats.
Okay.
And you might think, okay, animal medicine, but honestly, understanding hypoxemia here really shines a light on some, core biological processes relevant across the board.
Absolutely. So our mission today is to really unpack what hypoxemia is,
Yeah.
what causes it in our furry friends, and, well, why it's such a critical thing to understand and address.
And there's some really fascinating biology here, even if you're not in the veterinary field.
Definitely. Okay, let's jump in. What exactly is hypoxemia in basic terms?
Okay, so simply put, hypoxemia means there's a lower than normal level of oxygen, specifically in the arterial blood.
Arterial blood. Got it.
We measure this using something called the partial pressure of oxygen, or PaO₂.
PaO₂.
Yeah. And for healthy animals at sea level, that number, the PaO₂, should be somewhere between 80 and 100 millimeters of mercury, MeO-H.
80 to 100. That's the normal range.
Right. So when those numbers dip below 80 millimol Hg, well, that's when we start getting concerned. That's hypoxemia territory.
Below 80 is the red zone. And the sources mention this links directly to hemoglobin, doesn't it?
Spot on. That lower PaO₂ leads directly to something called hemoglobin desaturation.
Desaturation.
Think of hemoglobin like tiny buses in the bloodstream whose job is to carry oxygen.
Okay.
When the oxygen level in the blood, the PaO₂ is low, fewer of these buses get fully loaded with oxygen. And that's desaturation. The buses aren't full.
Got it. So the lungs aren't effectively passing the oxygen onto those hemoglobin buses in the red blood cells. Now, our sources lay out, I think, 6 main physiological reasons why this might happen.
That's right. 6 key underlying causes. It's a really good framework for understanding this.
Let's dig into those. What's the first one?
Okay, first up is low PiO₂. That stands for partial pressure of inspired oxygen.
Inspired oxygen, so the air coming in.
Exactly.
Yeah.
If there just isn't enough oxygen in the air the animal is breathing in the first place, well, their blood oxygen levels are going to drop.
Makes sense.
Think about being at really high altitude. The percentage of oxygen is the same, but the total air pressure is lower.
Right. Fewer molecules overall.
Precisely. So fewer oxygen molecules available with each breath, or, suffocation, poorly ventilated spaces. Same fundamental problem. Not enough oxygen going in.
Okay, less oxygen available in the air itself. What's the second cause?
The second is hypoventilation. Hypo meaning low, ventilation meaning breathing.
So underbreathing, basically.
Yeah, not breathing deeply enough or frequently enough. This causes carbon dioxide, CO2, to build up in the blood, which in turn pushes oxygen levels down. Now, lots of things can cause hypoventilation. Imagine something physically stopping the lungs from expanding properly, like fluid or air trapped in the chest cavity.
Okay.
Or an obstruction in the upper airway, making it hard to pull air in. Even muscular paralysis affecting the breathing muscles.
Wow.
Or certain diseases affecting the brain or nervous system that control breathing.
So various things preventing the mechanics of breathing from working right.
Right.
Now, the third cause.
Yeah.
The sources say this one is the most common.
Yes. Number 3, and this is the big one we see most often. A mismatch between alveolar ventilation and perfusion.
Okay, ventilation and perfusion mismatch. Break that down for us.
Right. So picture the tiny air sacs in the lungs, the alveoli like millions of tiny balloons.
Like balloons.
And wrapped around these balloons are tiny blood vessels, the capillaries. For oxygen to get from the air into the blood efficiently, you need 2 things happening perfectly at the same spot.
What are they?
You need good air getting into the balloon, that's ventilation, and you need good blood flow in the capillaries wrapped around that balloon, that's perfusion.
Air meets blood.
Exactly. A mismatch happens when maybe you have good air in the balloon but poor blood flow around it. Or the other way around, good blood flow, but the balloon isn't getting enough air.
Like a communication breakdown.
Kind of like the delivery truck shows up, but the warehouse door is closed. Or the door's open, but no truck arrives.
Gotcha.
And this kind of mismatch can happen with almost any lung disease. Think pulmonary thromboembolism, a blood clot blocking flow.
Right.
Pneumonia filling the air sacs with gunk. Pulmonary edema, which is fluid. even just being under anesthesia or lying down for a long time can cause parts of the lung to not ventilate well.
That really clarifies it. It's about the air and blood connecting properly. What's number 4?
Fourth is an alveolar capillary membrane diffusion defect.
Diffusion defect.
Yeah, this means there's a problem with oxygen actually crossing that super thin barrier between the air sac and the blood vessel.
The wall itself.
Exactly, but interestingly, the vet techs point out this is actually pretty rare as a primary clinically significant cause of hypoxemia in animals. That membrane is usually very efficient.
Okay, so usually not the barrier's fault. What about the last 2?
Number 5 is a right-to-left shunt. This can be either cardiac in the heart or pulmonary within the lungs.
A shunt, like a bypass.
Precisely. Blood is taking a shortcut. It bypasses the lungs, moving from the right side of the circulatory system directly to the left side without picking up oxygen.
Whoa.
This happens with certain heart defects present from birth, like tetralogy of Fallot or a hole between the heart chambers of ventricular septal defect, or even abnormal blood vessel connections within the lungs themselves called intrapulmonary arteriovenous shunts. Basically, the blood skips the oxygen filling station.
A serious detour. And the 6th cause?
Well, the 6th one listed technically circles back to the first low PiO₂, low inspired oxygen. It's just that fundamental issue of not enough oxygen being available in the air to begin with. It's often listed separately for completeness.
Right, got it. So those are the 6 main mechanisms. Now, the sources stress that hypoxemia isn't just a lung problem, is it? It hits the whole body.
Absolutely, because every single cell in every organ needs oxygen to function, period.
And some organs are needier than others?
Definitely. While all tissues need it, some have much higher demands. The cardiovascular system and the nervous system are particularly vulnerable.
Let's talk heart first. Cardiovascular system, what does low oxygen do there?
Well, when oxygen levels drop, it can lead to ischemia. That's a shortage of blood flow and therefore oxygen delivery to tissues.
Ischemia.
It can be localized, affecting just one area, or global, affecting the whole body. If that hypoxemia sticks around, it can trigger arrhythmias.
Irregular heartbeats.
Exactly. And eventually it can even lead to heart failure because the heart muscle itself isn't getting the oxygen it needs to pump effectively.
That sounds incredibly dangerous. And you said the nervous system is also highly vulnerable?
Yes, especially the brain and the central nervous system. These tissues burn through a lot of oxygen. They have very high metabolic rates.
Okay.
And here's the crucial part. Unlike some other tissues, they have practically no oxygen reserves, no backup supply.
No storage tanks.
None. So when the oxygen supply gets cut off or severely reduced, damage can happen incredibly quickly, sometimes irreversible brain damage.
That's terrifying.
It really underscores why acting fast in any situation where hypoxemia is suspected is just critical.
Absolutely. So shifting gears a bit, how might an owner at home even pick up on this? What are the clues, the red flags they might observe?
There are several things owners might notice, what we call historical findings. Things like episodes of coughing that seem unusual or persistent.
Okay.
Any obvious trouble breathing. Panting excessively when not hot or stressed, or real labored breathing. Especially open mouth breathing in cats, that's almost always a serious sign.
Right. Cats don't normally pant like dogs.
Exactly. Also, maybe a history of some kind of trauma, episodes of gagging,
Mm.
a noticeable drop in their energy levels, like they can't exercise or play like they used to without getting winded.
Exercise intolerance.
Yes. And then the more alarming signs, seeing a bluish tinge to their gums or tongue, that's cyanosis.
Blue gums. That sounds bad.
It is. It means there's significant deoxygenated blood circulating, or even, in severe cases, sudden collapse.
Okay, those are definitely things to watch for. Now, what about when the animal gets to the vet? What clinical signs does the vet look for during an exam?
During the physical exam, we're looking for tachypnea, that's abnormally fast breathing,
Fast breathing.
or dyspnea, which is difficulty breathing, labored breathing. You might see them using their chest and belly muscles more to breathe.
Increased effort.
Right. Some animals show orthopnea. They have more trouble breathing when lying down, so they might prefer to sit up or stand with their elbows out.
Trying to make space for their lungs.
Exactly. We'll check the mucous membrane color very carefully, looking for paleness or that cyanosis we mentioned.
Gums, Tom.
Yep. We listen closely to the lungs with a stethoscope for any abnormal sounds, like crackles or wheezes. Check the heart rate, often it's fast, tachycardia. And assess the pulse quality. Is it strong or weak?
Oh?
And of course, continued coughing or open mouth breathing during the exam are also big indicators.
So it's putting together the owner's story and the vet's findings.
hmm
Are there certain conditions or situations that make an animal more likely to develop hypoxemia? Risk factors?
Yes, definitely. Several things can increase the risk. A sudden move to high altitude is one we already touched on.
Right, the low PiO₂.
Any significant trauma, especially chest trauma, lung infections like bronchial pneumonia, diseases affecting the pleura, the lining around the lungs.
Right.
Being under anesthesia is a known risk factor, requires careful monitoring. Having pre-existing heart disease or chronic lung issues like chronic bronchitis in dogs or asthma in cats.
Makes sense those systems are already potentially compromised.
Exactly. Even just getting older, geriatric pets can have age-related changes in their lungs and heart that make them more susceptible.
Okay.
And then there's a whole category of diseases that increase the risk of blood clots forming pulmonary thromboembolism.
Ah, the VQ mismatch.
Precisely. Conditions like immune-mediated hemolytic anemia, Cushing's disease, certain cancers, pancreatitis, severe infections, sepsis. These can all predispose an animal to clots that might travel to the lungs.
Wow, that's a broad list.
Yeah.
It really drives home that hypoxemia can pop up in many different medical contexts. So a vet suspects hypoxemia. How do they confirm it and figure out the why, while ruling out other things that might look similar?
That's a key point. Signs like rapid breathing or distress can be caused by other things too, like just being really stressed or anxious, having a fever, head trauma, or even just being in pain.
Right, not always low oxygen.
So specific diagnostic tests are crucial. We need to confirm the low oxygen and hunt for the underlying cause.
And the gold standard test for measuring oxygen directly is that arterial blood gas, right, the ABG.
Exactly. Arterial blood gas analysis is the definitive test. It directly measures the PaO₂, the phyco₂ carbon dioxide, and the blood pH.
How's that sample collected? It sounds tricky.
It requires careful technique. We need blood from an artery, not a vein, usually the femoral artery in the hind leg, or maybe the dorsal pedal artery on top of the paw.
Okay.
The sample has to be collected anaerobically, meaning no air bubbles get into the syringe, and we use a special syringe coated with heparin, an anticoagulant, to stop it from clotting.
No air, no clots.
Critically important. And then analysis needs to happen fast. Ideally within 15 minutes if kept at room temperature,
15 minutes?
or maybe up to a few hours, 2 to 4, if it's immediately put on ice. Any delay, or if air got in, can give you a falsely high oxygen rating, which is misleading.
So you might miss the hypoxemia.
Exactly. Thankfully, many clinics now have portable blood gas analyzers, which lets us get results much quicker right there in the clinic.
That must make a huge difference. So ABG is key. What else? Imaging must be important too.
Oh, absolutely. Chest x-rays, thoracic radiographs are usually one of the first steps. They let us see the lungs, the heart silhouette, the airways, check for fluid or air where it shouldn't be.
Looking for those underlying causes like pneumonia or fluid.
Right. And echocardiography and ultrasound of the heart is vital if we suspect a cardiac cause, like heart failure or those congenital shunts we talked about.
See the heart structure and function.
Mm-hmm.
Okay. What about pulse oximetry, that little clip they put on your finger in the hospital? How does that work for pets?
Pulse oximetry is a great non-invasive tool. It gives us an estimate of oxygenation. It measures SO2, the percentage of hemoglobin that's saturated with oxygen.
They say O2, not PO2.
Correct. PO2 is the pressure of oxygen dissolved in the blood plasma. SO2 is about how full those hemoglobin buses are, but they're closely related.
How does the device work?
It uses a probe, often a clip, that shines specific wavelengths of light through a thin tissue bed, like the tongue, ear, lip. It measures how much light is absorbed by oxygenated versus deoxygenated hemoglobin.
And that tells you the saturation percentage.
Yes, and there's a generally reliable correlation. If the SO2 is above, say, 90%, the PaO₂ is usually above 60 mmHg, which is still low, but maybe not immediately life-threatening. And SO2 below 95% is generally considered abnormal, suggesting the PaO₂ might be below that 80 mmHg threshold.
Below 95% is the warning sign. You mentioned the tongue is a common spot for the probe.
Yeah, the tongue is often good because it's thin and usually has good blood flow, especially in anesthetized animals. But we can also use the lip, the pinna of the ear, the vulva or prepuce, the skin between the toes, or even a fold of skin on the flank. Sometimes moistening the area helps.
Are pulse oximeters always accurate, though? Are there things that can mess up the reading?
Oh, definitely. They have limitations. Anything that reduces blood flow to the area where the probe is, like low blood pressure, shock, severe coldness, or certain drugs that constrict blood vessels, can make the reading unreliable or impossible to get.
Core perfusion.
Exactly. Also, movement can interfere with the signal, and importantly, in cases of carbon monoxide poisoning, like smoke inhalation, the pulse oximeter can be fooled. It reads carboxyhemoglobin, hemoglobin bound to carbon monoxide, as if it were oxygenated hemoglobin. So you get a falsely high SO2 reading, which is really dangerous because the animal is actually severely oxygen deprived.
Wow, that's a critical limitation to know.
It is. The text also mentions some work on rectal probes, which might be more reliable for getting readings on awake, moving animals in the future, but tongue and ear are standard now.
Interesting. Okay, and finally, diagnosis-wise, the sources mention endoscopy or lung biopsy. When do those come into play?
Those are usually reserved for more complex cases, where the initial tests like blood gas and imaging haven't quite nailed down the underlying cause.
More invasive steps.
Right. Endoscopy lets us look directly inside the airways with the camera, maybe see inflammation, collapse, or obstructions, and take samples like washes or small biopsies. A lung biopsy, a larger tissue sample, might be needed for certain types of interstitial lung disease.
Okay, so we've figured out there's hypoxemia, hopefully pinpointed the cause. What's the treatment approach?
The absolute #1 goal is always to treat the underlying cause. Whatever is driving the hypoxemia needs to be addressed.
Makes sense. Fix the root problem.
But very often, the animal needs immediate support while we work on diagnosing or treating that cause. And that primary support is usually oxygen therapy.
Giving them extra oxygen, how is that done?
Several ways. We can use a snug-fitting face mask hooked up to an oxygen source, like an anesthesia machine or an E-tank, a portable oxygen cylinder,
Right.
or place small, flexible tubes called intranasal catheters into one or both nostrils to deliver oxygen right into the nasal passages. This allows them to eat and drink, which is an advantage.
Right, less restrictive than a mask.
Or, for some animals, especially smaller ones or cats, an oxygen cage might be best. It's an enclosed chamber where we can control the concentration of oxygen in the air they're breathing.
A high oxygen environment.
Exactly. The goal of all these is to increase the FiO₂, the fraction of inspired oxygen, basically making the air they breathe richer in oxygen.
Does oxygen therapy fix all types of hypoxemia?
It's very effective for some causes, like low inspired oxygen, obviously, hypoventilation, and those rare diffusion defects. It helps compensate.
Okay.
But it might not fully correct the low PaO₂ if the main problem is a severe ventilation perfusion mismatch or a large right-to-left shunt. Some blood might still bypass the oxygenated areas.
Right, the oxygen can't get to the blood if the blood isn't going to the right place.
Precisely. And oxygen therapy works best when the animal also has adequate blood volume and circulation to carry that oxygen around. In really severe cases where the animal just isn't breathing effectively enough on their own, even with supplemental oxygen, we might need to use positive pressure ventilation, PPV. Basically, a ventilator breathes for them.
Taking over breathing entirely. Okay. What about 4V fluids? You mentioned circulation is important.
Yes, fluid therapy plays a role, but it's very context dependent. It depends heavily on why the animal is hypoxemic.
How so?
Well, if the issue stems from low cardiac output, maybe shock, then fluids are critical. We might give intravenous fluids, sometimes along with drugs called inotropes that help the heart contract more strongly.
Supporting the pump.
But if the hypoxemia is due to congestive heart failure, where the heart is already overloaded and there's fluid in the lungs,
Pulmonary edema.
right, then we have to be very cautious with fluids. We usually use diuretics first to get rid of excess fluid, start heart medications, and only give fluids very carefully if needed. Giving too much fluid can make the pulmonary edema worse.
A balancing act.
Very much so. For different types of shock, hypovolemic, low volume, septic, infection, traumatic, aggressive fluid resuscitation is often needed. We might use crystalloids, colloids, hypertonic saline, sometimes even blood products.
Tailoring the fluids to the type of shock.
Exactly. And one specific point the sources make, for severe pulmonary contusions, bruising of the lungs from trauma, they often prefer hypertonic saline or colloids over large volumes of standard crystalloids initially.
Interesting nuance. So, fluids are crucial, but highly specific. Any other key medications besides oxygen and fluids?
The main other category mentioned specifically are bronchodilators.
Drugs to open the airways.
Yes. If bronchospasm, that tightening of the airways like you see in asthma or sometimes bronchitis, is contributing to the hypoxemia, then bronchodilators are really important.
Right.
Tributaline is given as an example. It can be given by injection, subcutaneous, intramuscular, or even IV, usually repeated every 8 hours or so as needed, to help relax those airway muscles.
Okay. Are there treatments that should definitely be avoided in certain hypoxemia situations? Contraindications?
Yes, we touched on one. Being very careful with aggressive fluid therapy in patients with heart failure or pulmonary edema, that's a big one.
Right, don't overload them.
And also, diuretics, while great for fluid overload, are generally not indicated and potentially harmful if the hypoxemia is due to shock, low inspired oxygen, diffusion problems, VQ mismatch, or shunts. They could worsen dehydration or low blood pressure in those cases.
So, using a right tool for the right job. Are there any general precautions vets need to be mindful of when treating these patients?
A couple of key things. One is that some of the inotropic drugs used to support the heart can, unfortunately, increase the risk of arrhythmias, so careful heart monitoring is needed.
Okay.
The other big one is oxygen toxicity. While oxygen is life-saving, too much for too long can be harmful.
Oxygen can be toxic.
Yes, breathing very high concentrations, generally considered over 60 or 70% for extended periods, usually more than 12 to 24 hours, can actually damage the lung tissue itself.
Wow.
It can lead to inflammation, fluid buildup, pulmonary edema, worsen lung injury, and in very severe prolonged cases, potentially cause seizures or even death. So the goal is always to use the lowest FiO₂ that maintains adequate oxygenation. We monitor closely and wean them off the high oxygen as soon as safely possible.
Use the minimum effective dose, essentially. So, once treatment starts, how do vets track progress? How do they monitor these critical patients?
Monitoring is constant. We're watching their clinical signs very closely. Are they breathing easier? Is the respiratory rate coming down? Is any cyanosis resolving? Are they more alert?
The outward signs.
Yes. Then, for objective measures, repeat arterial blood gas analysis is the best way to see if the PaO₂ is truly improving and CO2 is normalizing.
Checking the numbers directly.
Oximetry is also used for continuous, non-invasive monitoring of SO2 trends, but again, we have to interpret it cautiously, knowing its limitations, especially if perfusion is poor or the animal is moving.
Right. Keep the limitations in mind. What about complications? If the hypoxemia was severe or prolonged, what are the lasting concerns?
The biggest concern, as we mentioned, is potential brain damage.
From the lack of oxygen.
Exactly. Depending on how severe the hypoxia was and how long it lasted, the effects can range from subtle things like maybe some mild cognitive dysfunction or behavioral changes to more severe outcomes like dementia, persistent seizures, or even remaining in a coma or semi-conscious state.
Devastating.
It really can be. The other major complication mentioned is arrhythmias resulting from myocardial hypoxia, the heart muscle being starved of oxygen. These can sometimes be difficult to control even after the oxygen levels are corrected.
So, lingering heart rhythm problems.
Yes, potentially.
Yeah.
It just highlights how damaging oxygen deprivation can be to those critical organs.
Absolutely. Well, this has been incredibly thorough. It's clear that hypoxemia is a really serious condition.
It absolutely is. It underscores how vital that constant oxygen supply is and how many different things can disrupt it, affecting the entire body.
So I think the key takeaway for you, our listener, is that hypoxemia, not enough oxygen in the arterial blood, is a major red flag in our pets. It can stem from a whole range of underlying issues, from lung disease to heart problems to trauma, and the consequences can be severe if it's not recognized and treated quickly.
And spotting those early signs we talked about, the breathing changes, the cyanosis, the lethargy, and getting veterinary help fast is just crucial. Diagnostics are key to finding the why and guiding the right treatment.
Definitely. And maybe a final thought to leave you with. Stepping back a bit.
Yeah.
Given how absolutely fundamental oxygen is, right down at the cellular level for energy, it makes you think, doesn't it? What other conditions, maybe things that seem unrelated or even environmental factors, might be subtly impacting oxygen availability or utilization in the body, maybe in ways we don't always connect directly?
That's a really interesting point. Thinking about oxygen not just in crisis moments, but its role in overall health and maybe hidden stressors. Definitely food for thought.